project is about renal denervation. My name is Jessica.
My name is Carmen.
I'm Mollette.
I'm Katie.
The table of contents of what we're going to be going over is past and background, present state of the procedure, feature of the procedure, connections to BME, and bibliography.
Hi, I'm going to be taking you through the background. So before we get into renal denervation, let's talk about what it's meant to treat. Hypertension, also known as high blood pressure. Hypertension happens when the force of blood against your artery walls stays too high for too long, which forces the heart to work overtime. If left untreated, it can lead to serious conditions like heart disease, stroke, and kidney damage. We usually measure blood pressure with a cuff around the arm. In a manual reading, the doctor will use a stethoscope to listen for your pulse while slowly deflating the cuff. Nowadays, many clinics use automated machines. A normal reading is 120 over 80 milligrams mercury. If it's consistently higher, doctors might first recommend lifestyle changes like diet, exercise, or reducing stress, and if those don't work, then medications. Only if both of those options fails do doctors consider renal denervation as a treatment for resistant hypertension. Okay, now into the history. Before renal denervation existed, doctors used surgical procedures to lower high blood pressure. One of the earliest was a sympathectomy, where surgeons clamped parts of the sympathetic nerve chain running along the spine. The chains controlled involuntary actions like tightening blood vessels. By disabling it, they could lower high blood pressure. But it came with serious side effects, including postural hypotension, a dangerous drop in blood pressure when standing, and other bodily dysfunctions. In the 1950s, a more targeted approach called a splenectomy was used, where only the nerves supplying the abdominal organs, including the kidneys, were removed. It worked well for preservation, which was designed to be less invasive and safer. But after initial hype, a study in 2014, the Simplicity HTN-3 trial, challenged its effectiveness. This was a sham-controlled study, and surprisingly, it showed no significant difference in blood pressure reduction. However, the study had many flaws, and after later analysis and follow-up, studies show that RDN could still be effective if done correctly. As for how our class connects, we've learned how pressure and flow interact in the body. We even solved problems involving blood vessel blockages and stents, which is similar to how we might analyze complications after RDN, like arteries narrowing, tearing, or bleeding. By applying what we've learned, we can model how blood flow is impacted pre- and post-procedure and understand how healing or complications might play out.
Hi, so I'm going to be talking about the current state of renal denervation. Renal denervation has been studied for the past 2 decades, and the research is ongoing today because of the fact that hypertension is the leading risk factor for cardiovascular mortality and morbidity. So as Mollette said, typically for people with hypertension, we start by treating them using lifestyle changes like creating a low-sodium diet, exercising frequently, losing weight, and all the basics. We can look at the secondary causes using renal artery stenosis, severe untreated sleep apnea, or others. However, most people ultimately need a medicine to treat this, but if you're allergic to the medicines, it can create problems. This leads me to the first of the 2 main groups who benefit from renal denervation. The first is people who are allergic to these medicines, and the second group is people with resistant hypertension. There are 2 current techniques, ultrasound-based and radio frequency system, but they are both very similar in what they do. The first step to renal denervation is seeing a blood pressure specialist. They basically make sure everything is good, that there's no pseudo-hypertension, or it's not white coat hypertension. They also won't do the procedure if people have a GFR of under 45. Then you meet with a cardiologist and set up the procedure. In the procedure, they start with a renal angiogram and inject contrast via an artery in the leg to look at the blood supply to the kidneys. If the blood supply is good, then a catheter is inserted into the artery. Then the machine or generator turns on, and the ultrasound or radio frequency ablation is turned on inside the renal artery. The catheter is removed and nothing is left inside the body. This works because let's picture the heart and kidneys are married. The procedure disrupts the nerves on the renal artery and therefore should theoretically lower blood pressure. If there's excess activation of nerves in the renal artery, we retain sodium, and then more fluid, and then increased heart rate, and then increased blood pressure. In this procedure, the average person gets 5 to 6 millimeters of mercury reduced, which is around 1 pill. The surgery takes around 40 minutes, costs around $10,000 to $15,000, and is an outpatient procedure. A problem with this is that the response varies between people. Some people have no reduction, and some people have a strong blood pressure drop. There are also no clinical procedures as to what response happens in what person. It also takes around a couple months to see the blood pressure drop. One researcher at USC is Dr. Vidi M. Capis, who is studying the role of renal denervation in patients with resistant hypertension. If I was in an undergraduate lab working on this, I think the mass flow rates concept we learned in BME 101 would best help me understand the idea of hypertension, and I also think that KVL and KCL would help me solve an aspect of the problem if there are problems in the electrical design of the ablation catheter.
In this slide, I will talk about the problems that will be solved and remain in terms of the future of renal denervation for treating high blood pressure. Renal denervation stands at a critical juncture in hypertension treatments. In the near future, we'll make important strides in identifying optimal candidates through predictive biomarkers, enhancing treatment response rates, and achieving more consistent blood pressure reduction. However, significant challenges remain across multiple fronts. Our devices still require invasive procedures with inherent risk of over or under treatment due to imperfect nerve targeting and inconsistent energy delivery. Patient-specific issues like anatomical differences and varying diseases of physiology continue to affect outcomes, while clinicians face practical barriers including specialized training requirements, higher costs compared to medication, and limited long-term data. Perhaps most crucially, we still lack fundamental scientific understanding in key areas, from nerve regeneration patterns to compensatory nervous system responses and optimal treatment parameters. These collective challenges currently limit RDN's widespread adaptation, despite its considerable potential. In this next slide, of why these problems remain impossible suggested solutions for improvements. These persistent challenges stem from four fundamental realities. First, the biological complexity of deeply embedded renal nerves makes precise targeting inherently difficult. Secondly, hypertension multifactorial nature means renal nerves are just one piece of a larger physiological puzzle, further complicated by individual anatomical variations. Third, our current technology lacks the precision needed for consistent results, requiring better devices, patient stratification, such as repeating renal denervation multiple times to patients, and clinical evidence. Finally, these limitations currently regulate RDNA to niche use. However, we're pursuing innovative solutions across three fronts. Mechanistically, we're developing approaches to better modulate nerve activity, renin release, and sodium balance. Clinically, we're positioning RDN as a complementary therapy after medication optimization. And most importantly, we're refining patient selections through biomarkers, improving procedure safety, and aligning RDN advances with comprehensive treatment paradigms. Together, these advances are paving RDN's path for specialized interventions to mainstream solutions.
Now talking about the connections to VME, the main components of renal denervation would be the catheter and the ultrasound machine, which works as an energy generator, sending pulses of energy into the artery. And looking at a counting equation point, we would be able to use it towards the net charge and energy flow going from the ultrasound machine into the catheter. Then, as Katie stated before, KVL is also a good equation to know when calculating the energy coming into the renal artery. As for future BME coursework that you may encounter, BME 302L, which is medical electronics, is a class touching upon electronic design and measurements for medical applications, which is exactly what renal denervation is, where we would have to talk about or explore the ultrasound machine and how it works and its functions towards renal denervation. BME 413, which is bioengineering signals and systems, which is a class where you learn about linear signals and system theory, which is related towards the energy dissipated in renal denervation. A last class that you may encounter is HBio 310L, which is human anatomy, which is the class where you learn about the human body and organ functionality, which is important when learning or when doing the procedure of renal denervation, because you wouldn't want to interfere with any other organs that are surrounding the renal nerve. This is our bibliography with some of the sources that we used for our research. And that concludes our presentation. Thank you.